Those loop diuretics were pretty intense, right? By blocking sodium absorption along the ascending limb, the entire concentration gradient of the kidney broke down, leading to substantial diuresis. Loop agents, therefore, were especially useful for combating all that fluid retention that accompanies kidney, liver, and heart failure. Our next agents, the Thiazides, are a little more relaxed. Yeah, they can help a bit with volume overload, especially during heart failure. But we're going to focus on a few non-edematous states where thiazide-induced sodium excretion can be especially useful, during the management of hypertension, for example. And while loop diuretics promoted excretion of calcium, we'll soon see that thiazides have the clinically useful ability to enhance calcium resorption, helpful for preventing renal calcium stones. This is all happening at the distal convoluted tubule, the theme of our next attraction. The distal convoluted tube slide. You know, nothing says diuresis like a public pool. So on that note, don't open your mouth underwater. Watch out for areas of calcium precipitation around the pool, and let's jump in. Oh, and if you need to get oriented, just check out the convenient park map. Notice that we've worked our way to a more distal area of the park, strangely reminiscent of the distal convoluted tubule of the nephron. Our next family of diuretics, the thiazides, are going to exert their effects here. It's way more relaxed though, I promise. While the proximal procart tract and the loop-de-loop of Henle were sites of significant sodium resorption, only about 10% of filtered sodium is reabsorbed here. The solute most relevant to diuretic action at the distal convoluted tubule is sodium chloride. So watch out for the accumulation of sodium chloride crystals around this saline pool. Also, keep your eyes peeled for those recurring salty sodium peanuts. Remember, wherever sodium goes, water goes too. I think I had my fill while we were waiting in line at the loop, but if you're still hungry, there's another one of those banana vending machines. Remember that the potassium banana vending machine powered by the 3P batteries is our recurring sketchy symbol for the sodium-potassium ATPase. Like the loop-to-loop of Henle, the sodium-potassium ATPase in the basolateral membrane pumps reabsorbed sodium into the interstitium in order to maintain a lower intracellular sodium concentration. This makes room for more sodium absorption from the tubular lumen. At this attraction, the tubular lumen of the distal convoluted tubule will be depicted by the tube slide and saline pool. Therefore, the area around the pool represents the intracellular compartment. Like the thick ascending limb of the loop of Henle, the distal convoluted tubule is relatively impermeable to water. Sodium chloride reabsorption, therefore, further dilutes the tubular fluid. This solute transport is accomplished by an electrically neutral sodium chloride cotransporter. So take a look at this saline slide. While most of the water is staying in the lumen, there is some salty sodium chloride residue accumulating on the pavement, in the intracellular compartment, that is. Let these pool cleaners scraping the sodium chloride into specially marked bins at the edge of the pool represent the sodium chloride cotransporter on the apical membrane. At the loop of Henle, I briefly described how other cations like calcium and magnesium are reabsorbed because backleak of potassium causes a positive potential in the lumen, pushing out more cations. Well, at the distal convoluted tubule, potassium doesn't recycle across the apical membrane in this way. So there's no lumen positive potential in this segment. Instead, calcium is actively reabsorbed by the epithelial cells via an apical calcium channel and basolateral sodium-calcium exchanger, a process regulated by parathyroid hormone. This active resorption of calcium is depicted by this kid here plunging down the convoluted slide as his calcium ice cream is thrown from his hands, tumbling into the intracellular space below. Yeah, this slide seems pretty extreme. If you're lame, I can tell you need a little more excitement. How about we face our acrophobia and make our way toward the thiazide high dive? Uh-oh. See that kid with the unsightly pasty thighs? He's a regular around here. Every time he gets up there, he just can't do it. He can't take the plunge. Let his pale thighs exposed by that form-fitting Speedo remind you of the diuretic class, the Thiazides, which act at the distal convoluted tubule. The Chloro brand swimwear should remind you of the prototypical thiazide, hydrochlorothiazide, as well as chlorthalidone, a thiazide with longer duration of action. Yep, frozen in terror. He isn't looking too good up there. Oh, good. One of the salt scrapers is heading over to save him. Oh, careful with the salt. Thiazides work by inhibiting sodium chloride reabsorption in the distal convoluted tubule by blocking the sodium chloride cotransporter at the apical membrane. It was previously represented by our trusty salt scraper diligently bringing sodium chloride back into the cell. Well, now they're distracted by those quivering, pasty thighs, inadvertently dumping that sodium chloride back into the tubular lumen. And remember, water follows all that extra sodium in the tubular lumen, ultimately leading to diuresis. Okay, remember back at the Loop of Henley when that furious furosemide kid would just not give up his calcium ice cream? Well, because it stayed in the lumen, this promoted calcium excretion. In contrast to the action of loop diuretics, however, thiazides are actually able to enhance calcium reabsorption. This is depicted by another careless chloro Speedo kid with those pasty thiazide thighs sliding down the intraluminal compartment of the convoluted tubule. Notice that he's dumping an even larger amount of ice cream back into the intercellular space, right on one of the pool cleaners, no less. The enhanced calcium reabsorption may be the result of effects at both the proximal and distal tubules. In the proximal tubule, thiazide-induced volume depletion leads to enhanced sodium and passive calcium reabsorption. In the distal tubule, thiazides block sodium entry into the epithelial cell. A decrease in intracellular sodium levels enhances sodium-calcium exchange at the basolateral membrane, again leading to increased resorption of calcium. All right, let's cover a few of the clinical uses of thiazide diuretics. Thiazides are one of the first-line agents used for the initial treatment of primary hypertension. So, notice how that convoluted water slide is powered by some industrial-sized high-pressure pipes that look like they're about to burst. These high-pressure pipes are our recurring symbol for hypertension treatment. Thiazide diuretics decrease blood pressure by decreasing intravascular volume and reducing cardiac output. Recall that those furious loop diuretics were useful in severe hypertension, especially in states of fluid retention such as renal insufficiency, cardiac failure, and cirrhosis. Well, thiazide diuretics, on the other hand, are appropriate for most patients with mild or moderate hypertension and normal renal and cardiac function. Also, it turns out that chlorthalidone may be more effective than hydrochlorothiazide due to its longer half-life. Also recall from the loop-de-loop of Henley that loop diuretics are your first-line agents for managing edema associated with acute or chronic heart failure. In mild chronic heart failure, a thiazide may be tried as well, though a loop diuretic is usually necessary. In some instances, salt and water retention may become so severe that a combination of thiazides and loop diuretics is used. Let this floppy failing heart balloon, held by the friendly poolside balloon salesman, represent the use of thiazides as adjunctive treatment in heart failure. Wait, do you hear that trickling noise? Not again. Oh, never mind. They just turned on that urinating child fountain. You know, for some European flair. This never-ending, crystal-clear stream is our recurring symbol for the treatment of nephrogenic diabetes insipidus. In diabetes insipidus, two things could happen. Either you're not producing ADH, as seen in central diabetes insipidus, or you're just not responding to ADH, as seen in nephrogenic diabetes insipidus. While supplementing ADH or antidiuretic hormone is the treatment of central DI, thiazide diuretics can reduce polyuria and polydipsia in nephrogenic DI. This paradoxical effect is due to a hypovolemia-induced increase in sodium and water reabsorption in more proximal segments of the nephron. This avoids having to rely on the terminal collecting duct for water reabsorption, where ADH isn't working too well. Oh, now I see why that kid with the pasty thighs looks so terrified on the convoluted water slide. There's a dangerous buildup of calcium in the water. Recall that thiazide diuretics enhance calcium reabsorption at the distal convoluted tubule, thus reducing urine calcium concentration. This was signified by the calcium ice cream tumbling into the intracellular space below. Well, this hypocalciuric effect can be useful in patients at risk for developing calcium stones. Approximately 2/3 of kidney stones contain calcium phosphate or calcium oxalate. Many medical conditions can cause hypercalciuria, including hyperparathyroidism, hypervitaminosis D, and sarcoidosis. So, as the pool attendant quickly avoids a lawsuit and pulls the calcium out of the lumen, remember that the calcium stones seen in these patients or in any condition where there is a defect in proximal tubular calcium reabsorption can be treated with thiazides. As you might imagine, this enhanced calcium reabsorption may also benefit patients with osteoporosis. Studies have shown that thiazide therapy attenuates bone loss and may reduce fracture risk. Although the effect is modest, keep in mind that a thiazide diuretic is a reasonable choice if a patient with osteoporosis has hypertension or nephrolithiasis. See that fractured piece of chalk on the chalkboard, reminiscent of an osteoporotic bone? Let this pessimistic lifeguard who's retrieving a brand new, intact piece of calcium chalk remind you of the thiazide's ability to increase bone mineral density in patients with osteoporosis. Oh good, it looks like one of the kids is trying to lure Frady thighs away from the high dive and back to safety. And what's more enticing than a freshly scooped cup of calcium ice cream? All this enhanced calcium reabsorption we've been talking about can cause hypercalcemia. This is represented by this child raising up the ice cream, way up there high on the high dive. This elevated calcium ice cream is our recurring sketchy symbol for the risk of hypercalcemia during thiazide therapy. Although hypercalcemia is not too common, thiazides can unmask hypercalcemia from other causes, such as hyperparathyroidism, carcinoma, and sarcoidosis. Yeah, that's not working. Oh, there we go. Candy and butter. Come on, if the thought of all that sugar and fat coursing through your veins isn't enough incentive to back away from the board, I don't know what is. Let that candy jar and that cholesterol-ridden stick of butter raised up on the high dive represent the hyperglycemia and hyperlipidemia provoked by thiazides. Hyperglycemia may occur with high-dose thiazide therapy in diabetic patients, as well as those with even mildly abnormal glucose tolerance tests. The effect is due to both impaired pancreatic release of insulin and diminished tissue utilization of glucose. As for the buttery spread, thiazides cause a 5 to 15% increase in total serum cholesterol and LDLs, although these levels may return towards baseline after prolonged use. So, hypercalcemia, hyperglycemia, hyperlipidemia. Are you getting the picture yet? Hydrochlorothiazide at the high dive makes a lot of different lab values, well, high. Not only that, I think I'm sensing an elevation in the level of irritation among kids waiting in line. Remember that bored nitwit waiting in line at the loop-de-loop of Henley? Well, it looks like the thiazide high dive is also at a standstill, so she once again takes out the old needles and yarn. Like loop diuretics, hyperuricemia is a relatively common finding in patients treated with a thiazide diuretic and may lead to gouty arthritis. And like loop diuretics, the mechanism involves hypovolemia-associated enhancement of uric acid reabsorption in the proximal tubule. Treatment of diuretic-induced asymptomatic hyperuricemia is not necessary. But if your patient starts experiencing symptoms of an acute gout flare, It's time to start a concurrent urate-lowering drug such as allopurinol. And you know what? We're not done elevating serum lab values. See those charming, collectible, floating lithium balloons? Think lithium lithium. It's our recurring sketchy symbol for increased lithium levels. Thiazide diuretics decrease the renal clearance of lithium, an agent used to manage bipolar disorder. So, serum lithium levels must be carefully monitored in patients receiving both medications. Quick side note, listen again for that endless clear nephrogenic stream trickling out of our DI fountain. Lithium is a common cause of nephrogenic diabetes insipidus. Thiazide diuretics are a good treatment option as long as you keep an eye on those lithium levels. Oh, great. Have we really resorted to throwing things again? That potassium-depleted banana peel is our recurring sketchy symbol for hypokalemia. Similar to loop diuretics, thiazides increase sodium delivery to the collecting duct, this time by blocking the sodium chloride cotransporter in the distal convoluted tubule. This leads to increased potassium secretion by the collecting duct in exchange for sodium reabsorption, which leads to hypokalemia. Uh-oh, now they're turning on each other. See how that bully is smacking those sodium peanuts out of the poor victim's hand? Well, spilled peanut shells are our recurring symbol for hyponatremia, one of the side effects of thiazide therapy. Recall from our last sketch that loop diuretics function by inhibiting the absorption of solutes within the thick ascending limb, a process that's critical for the maintenance of the corticomedullary concentration gradient. As a result, patients on loop diuretics can't concentrate their urine and lose both salt and water. In contrast, patients taking thiazides have a normal corticomedullary concentration gradient and are better able to retain free water. Therefore, patients taking thiazide diuretics mostly lose sodium and may develop hyponatremia. As the line turns into some kind of hideous scene from Lord of the Flies, take a look at those rotten eggs getting tossed around by the enraged kids. Those stinky sulfurous projectiles are our recurring sketchy symbol for sulfa drugs. Thiazides, therefore, may cause allergic reactions, but this risk is extremely rare. There's one important similarity to loop diuretics that I want to emphasize. See that persistent cleaner still squeezing away at the bottle of alkaline bleach? He represents the contraction alkalosis side effect that can be seen with thiazide therapy. Just like the loop diuretics, thiazides can cause metabolic alkalosis by hypovolemia-induced renin production by the kidney. More renin means more aldosterone, which causes increased H+ excretion at the collecting duct. More renin also means more angiotensin II, which leads to increased sodium bicarb reabsorption at the proximal convoluted tubule. Either way, you've got alkalosis. All right, that cleanup's gonna take a while. I think it's time to sum up this sketch. The distal convoluted tube slide incorporates all the events that occur at the distal convoluted tubule. Normally, sodium chloride is absorbed by those salty sodium chloride salt scrapers. Calcium, as well, is actively reabsorbed, as depicted by the calcium kid actively sliding down the tubule, dropping his ice cream into the cell. Thiazides, as depicted by Theodore Roosevelt up on the thiazide high dive, blocks the sodium chloride channel, leading to natriuresis. It actually enhances calcium resorption, which can be useful for treating calcium renal stones. Remember, this slide is powered by some high-pressure arterial pipes, which highlights thiazide's use as a first-line agent for managing primary hypertension. Besides pasty thighs, a few lab values will be accentuated as well. Up on the high dive, remember high serum glucose, high cholesterol, hypercalcemia, and the recurring bored nitwit representing hyperuricemia. You know what? I think it's time to call it quits. This line isn't going anywhere. I'm hungry. You look dehydrated. Before closing time, why don't we head over to the food court? The mineralocorticoids court. It'll make more sense once we get there.